Welcome, everyone. We're gonna go ahead and get started. This session will be about aplastic anemia. So welcome, everyone. I'm Lee Clark, the Director of Patient Services for the Foundation. After this session, there will be a question and answer session, but when asking questions, if you could do me a favor, wait for me to bring you the microphone. We want to make sure everybody can hear the question and that the question is also captured on the recording. When asking questions, I do also ask that you keep your questions general in nature. Our expert cannot answer any questions related to your personal health care. Our expert today is Swapna Thota. Dr. Thota is a professor of medicine at the University of Tennessee Health Science Center in Memphis. Her clinical practice focuses on bone marrow failure states, including patients with aplastic anemia and related disorders, acute leukemias, myelodysplastic syndromes, and myeloproliferative neoplasm states. It's my pleasure to welcome Dr. Thota.
Good morning. Thanks for being here. I know some of you travel from a distance to be here. It's my distinct pleasure to be with you all this morning. Down in Memphis, we are being poured down by Hurricane Francine, so it's like really beautiful to see the sun out. It's been like 2 or 3 days since I saw the sun, so it's a bright day with you guys to be here. I'm much more warmer and feeling cozy down here. So I do focus on bone marrow failures. It's a great passion of mine to be helping with rare diseases. So I try to keep it as simple as I can. If something, you don't have to get all the information I'm sharing today, even if you can get 20% of the highlights, I think that's a win-win for today. So just for historic, we all stand on the shoulders of giants who have educated about this disease or have contributed towards this disease. We have known aplastic anemia was first described in literature in 1800s by a pathologist who saw a young woman who came in with high fever, anemia, and bleeding. And they did a bone marrow biopsy and found an empty bone marrow, what was called as aplastic. Okay, that eventually was described and consolidated by many other physicians and came to be known as aplastic anemia. That's Paul Ehrlich, who is the pathologist who first described it and is a Nobel laureate for several of his discoveries, both in immune disorders as well as infectious disorders. Aplastic anemia is one of the classic immune-mediated bone marrow failure conditions. Okay, it's rare, and we're going to talk about what being rare means at one of our other sessions. So it does take some effort to find the experts in the community because it's a rare disease. There are only about 500 to 600 cases being diagnosed in the United States each year. That's about 1 in a million. So I always start off with my aplastic anemia patients saying that you're 1 in a million, makes them feel special. It's a hard journey, but they are 1 in a million. If you look at the geographic variations, there is perhaps some environmental factors, radiation, especially in Asian countries, you see a little bit more higher incidence. It could be genetics too. We don't know the exact cause. But in Thailand and in Japanese registries, you see the incidence rates are like 10-fold higher. Like in Japan, they describe 8 to 10 patients per million. There's a biphasic distribution. I actually practice both at St. Jude and University of Tennessee, so I see a age spectrum and differences in presentation for this disease. So you see there's a pediatric population where there's a peak incidence of this, followed by, again, in your 5th and 6th decade of your life, that there is a second peak of, this is very common for immune disorders. If you study lupus or any other non-blood related immune disorders, it's usually bimodal in distribution. I think that's what, it's another story that emphasizes the immune-mediated pathogenesis of aplastic anemia. I wanted to talk about 2 recent cases that I have had the privilege of helping. One's an elderly woman who came repetitively to emergency rooms feeling dizzy, almost about to pass out, and was found to have really low blood counts. Okay, The local physicians did a thorough workup. When we come across a patient with low blood counts, we look for different causes. Everything was done appropriately and did not identify any reason. So they subsequently referred to us. We did a bone marrow biopsy, and as you can see, it had very few cells in the bone marrow. We described as hypocellular or less than 5% cellularity in this particular case. We were able to detect a small PNH clone, which helps us make such a diagnosis. And other testing that were sent did not show any other cancers or any other causes for her low blood counts. We subsequently, because of the age, she was not a transplant eligible patient. So we went ahead and treated her with immunosuppressive therapy. She's into her it takes time. That's another thing we're going to talk about later in the presentation. She's just now experiencing some transfusion independence while going through treatment for her aplastic anemia with what we call the triple regimen or immunosuppression regimen. So I'm really excited to see some of the alleviation of blood transfusion independence that she's enjoying, and hopefully that continues into a full response for her within the next few months. This is the most recent case that I have come across and stands a little bit different to the previous case I talked about. We came across an African immigrant who, as a child, had some transfusions, some viral illnesses, moved to be close to his extended family to Memphis, Tennessee. The day after coming to Memphis, Tennessee, he actually passed out and was brought into emergency room with an extremely low hemoglobin. His other blood counts were also really low. Again, same workup, couldn't find anything. Local hematologist did a bone marrow biopsy. His bone marrow for a young man should be about 80% cellularity, but in him we only found 10 to 20% cellularity. His story was unique. He fractured several bones by only being in second decade of life. He has a rash on his body and his liver tests were abnormal. Okay. All these syndromic features we call makes us think about, oh, is this hypocellular bone marrow just aplastic anemia, or we need to do more extensive testing? Just seeing more pediatric cases, they have different causes of aplastic anemia, which I'll go into later. We entertained a diagnosis of disc keratosis congenita, which is a type of bone marrow failure. And currently is undergoing testing for it and is being treated with a medication called danazol. So I'm really curious to perhaps at one of our other meetings give update about what the testing showed. But it just stands strikingly different between how a young patient might have a broader differential diagnosis with low blood counts, as opposed to what we see in 5th, 6th, 7th decades of our life of a classic, what we call acquired aplastic anemia. Mm. Oh. All right. So I think most of you are familiar with the types of cells that are present in our blood system. We talk about 3 main bloodlines: red blood cells, which is the energy giving cells, carries oxygen around the body. If you're low, you're called anemic. And platelets, which are the cells that come and stitch up if you're losing, have any cuts or any bleeding. Those are the tiny cells, but the mightiest cells that help us clot. And then we have our white blood cells, which is our immune system. Okay. In aplastic anemia, you will have low blood counts. So you'll have symptoms from the low blood counts, which is your friends might tell you you look a little pale, or you might feel extremely tired. A lot of people in 5th, 6th decade explain their fatigue to their age, but it's more fatigue than that. It's an extreme fatigue you feel because you're anemic. You feel winded, short of breath from being anemic. And sometimes people, like the original case that was described, they have infections and come in with recurrent infections. So some people might have a rash and other unusual symptoms, but these are the most common symptoms. Symptom onset can be really acute, so it is like weeks to months, or it can be chronically building over time. My 72-year-old patient that I talked about had a few emergency rooms, needing blood here and there, and then presented to me a few months later. So it can be a little bit subacute, acute. There's no classic description. So the symptoms can vary over a period of time. And the bone marrow, when we do it, It's supposed to look that pinkish bluish in the right picture when it's fully cellular. But for an aplastic anemia, you see how there's a lot more white. There's more emptiness. There's usually fat in it. So it's replaced by fat because the total number of cells is less. So, what does it look like for you when you're being diagnosed with aplastic anemia? Depending on the severity, how your blood counts are, you may be in the hospital or you may be in an outpatient setting. You may need a few transfusions even before you get diagnosed because your physicians are trying to make you feel better. They may provide you some medications. If your white blood cell count is really low, to prevent infections, they may give you some medications as supportive care while they're doing their diagnostic workups. You go through a procedure called bone marrow biopsy. Some of you have probably gone through this procedure. It is, it hurts to get it, but I classically describe it as a tooth pulling, but instead of working on a jawbone, we work on a hip bone. Most centers have different forms of sedation or anesthesia they can help with, and some patients do fine with just local anesthesia. So you will have to go through this procedure called bone marrow biopsy, typically done in an outpatient setting and with a light sedation. And we do a lot of testing on the samples that are obtained from this bone marrow biopsy to end up with the diagnosis of what's causing the low blood counts. One of the most critical elements your physician is thinking through while he's trying to treat you is to really make sure we have the right diagnosis. So they're thinking of many things that I thought about for my two cases that talked about. Is it an infection? Is it just as simple as a nutrition deficiency? Is it a virus? Is it some other immune problem that's causing this? Because bone marrow, our organs talk to each other. Any disturbance in anything can really irritate the bone marrow. So we're really looking at you as a whole, getting to know your symptoms and doing a lot of testing to really make sure all these low blood counts are not explained by something else that can be fixed in a different way. So when we are doing the testing, you will go through blood testing and the bone marrow testing like I talked about. It takes time. You do the test, and most of you may have experienced that agony of waiting for the results, the 2 weeks, the 3 weeks till your doctor finishes, because some of the tests are DNA testing. So it does take some of the cells to grow in like little petri dishes and then taking pictures of it and things like that, extracting DNA and studying those material. So it does take about 2 weeks for all of those testing to come back. So sometimes that's the delay in for your doctor to come back with you and tell you, this is what I have found so far, this is what I think is happening with you. And the other complicating thing and the reason for you to meet with an expert to come up with this diagnostic test, it's not a diagnosis where you send out a test and it comes back saying aplastic anemia. There's no positive or negative test for this. It is really somebody thinking through every differential possible, everything that can explain, and it doesn't look like this, it does not look like this. Coming down that algorithm, putting all the tests together, and the clinician that's treating you talking also with the lab doctor, a pathologist. Oh, what do we think is going on here? And then the clinician tells you, usually for other cancers or other thing, you'll see tests come back saying breast cancer or prostate cancer or whatever, right? This does not, you will just see a description of a bone marrow that says low blood counts and a lot of medical terminology, but it will not come back. It's your clinician that will tell you this is aplastic anemia. And which is why there is a certain need to work with at least one time going and seeing an expert to confirm that you do in fact have aplastic anemia. Why is that important? Because some other diseases that have much different prognosis, much different way of handling things, look like aplastic anemia. A major basket is called MDS or myelodysplastic syndrome, the condition that's being talked about next door. It's actually a blood cancer where aplastic anemia we describe as immune mediated bone marrow failure. And there are other types of immune mediated bone marrow failure like pure red cell aplasia, like LGL, and they can sometimes mimic aplastic anemia. Okay, so these are all things we are thinking about talking to our lab doctor because there's such an overlap. We'd really try and make sure none of these other baskets fit you. They are not your diagnosis. And the most important one to discuss, or any friends you're helping with this diagnosis coming down, your doctor really made sure that this is not MDS, right? That's the most important question. You'll be advising your friend to be discussing with their treating physician. So like I said, it takes some time. About 2 weeks is okay, I think, to take from bone marrow biopsy until you land to the right doctor, getting a bone marrow biopsy. It's about 2 weeks on an average that most institutions take to come up with the diagnosis. So how do I make, or any expert in the field, make aplastic? Like I said, there's no test that comes back positive. So we talked about low blood counts. We talked about your bone marrow looking empty. And there is a sister disorder called paroxysmal nocturnal hemoglobinuria. For short, we call it PNH. It co-occurs. There are two sister disorders. They come in hand, and having that PNH helps me make a diagnosis of aplastic anemia, especially the acquired type of aplastic anemia. And then we'll talk about the types of aplastic anemia. We study DNA. I told you your chromosomes are supposed to look normal. Sometimes there are genetic changes that that are a little bit more specific to aplastic anemia than MDS. These are called PGA mutations or BK. So we take a look at all these tests and help you make the diagnosis of aplastic anemia. Because I do work in my adult population with patients at different levels of education or health awareness, I play the role of their advocate and being their physician. So I give them the questions. I'm going to do the same today. I'm like, what questions do you need to ask your doctor if you're diagnosed with aplastic anemia? You have to ask them what kind of aplastic anemia you have. Is my family at risk for, if you're wondering about it, is my family at risk of developing this condition? Do I need treatment? How long can I wait if I need treatment? What if I get pregnant? Like I said, there's younger people too that go through aplastic anemia, right? So once you have this condition, is it safe to get pregnant? What are some of the long-term complications of having this diagnosis? And what about food, diet, sports, exercise? How do we manage all that? And what does survivorship look like by having this diagnosis? So over the next few slides, I'm just going to address each of these questions, and hopefully you're already thinking through some of this. So my answers are hopefully the same answers your physicians have told you. All right, types of aplastic anemia. They're different baskets. Like the child I described, he was, I believe, born with some genetic defect that made him have an empty bone marrow. We call those inherited. In medical terminology, we call them Mendelian disorders, something they're born with, and they have different names. I've named the most common: Fanconi anemia, SBDS, dyskeratosis congenita, which is the case I was talking about, or Diamond-Blackfan anemia. These are different genes that are causing the disease, and they affect different organs in their body, including the bone marrow biopsy. It's not an immune-mediated thing. It's just a genetic disorder they're born with. Most adults have what's called acquired aplastic anemia. They were not born with it. It happened as they are going on through their life, okay? Sometimes it just happens with no reason or association. Sometimes we hear somebody got pregnant and then blood counts went low. They thought it was just iron deficiency, but it was more than that. Somebody came down with an unusual immune disorder. Eosinophilic fasciitis is a classic example of it. And then they developed an empty bone marrow. Or you see hepatitis is a common thing. People had like viral illness. And then months later, they developed. So you have some association of exposures in a small subset of people. These are all called secondary acquired aplastic anemia. We don't know if it's an association or really the etiology. Some of the times we are able to tell, it's like Bactrim is a medication. Gold salts, when people used to use it for some immune disorders, there's certain medications we know that caused aplastic anemia, but for others, it's mostly an association that we have come across and again over decades and put it in this basket of secondary aplastic anemia, but still an acquired type of aplastic anemia. So if we take adults as a group, we can't really tell in 70% of the cases. In 70% of the cases, we can say this is acquired aplastic anemia. In only a small percentage of adults, we can think of something they were born with. And in about 20% of the cases, we really don't know. There's no association, it just happened. Okay. In kids, this numbers look a little bit different. The genetic causes are a little bit more prominent than the acquired causes. So those are the types, broadly acquired and inherited. But if you look at the severity, this is the most important thing, that when you get diagnosed with acquired aplastic anemia, your doctor puts in all your numbers in a calculator and tells you, I think you have moderate aplastic anemia, or I think you have severe or very severe aplastic anemia. And what are the numbers they're paying attention to? They're looking at your bone marrow biopsy, making sure it has less than 25% cellularity. And they're looking at your white blood cells, your baby red cell count, which we call as reticulocyte count, and platelet numbers. They put in, then we categorize each person as either moderate or severe or very severe, and it has implications as to how we manage the condition. So, is my family at risk? So, this doesn't apply for anybody with acquired. You were not born with it, you developed it later. Okay. Whatever the associations are for most acquired aplastic anemia patients, your family is not at risk for developing aplastic anemia. But the kid that I described who has an inherited cause, they will, if he has to have progeny, they are going to have children. Children are at risk of getting that kind of aplastic anemia or that Mendelian disorder. And for each of the condition, the type of inheritance is different. It can be X-linked, autosomal dominant, meaning every child is going to have it. If it's autosomal recessive or X-linked, then only 50% chance that the child is going to have it. So this is a very precise conversation to your diagnosis, and you have to meet with your treating doctor and have them think through this question if it is one of the things that is bothering you. Okay. So do I need treatment? Not always. Moderate aplastic anemia, your blood counts are low, but not low enough that you're needing transfusions, not low enough that we called you immunocompromised, or you're not getting infections, although your numbers are a little bit low. Sometimes we then just watch and wait. We just do call what's up. You still need to follow with your doctor, because people may start out as moderate aplastic anemia, but then quickly progress to severe aplastic anemia. Some are moderate, stay there for a really long time. I diagnosed a girl when she was like 13, she's 21, stays in that moderate aplastic anemia zone, never needing treatment. She's like, do I really have this? Because I don't feel it, but every time I see her numbers is a little bit low, never really needing treatment. I didn't need to fix her numbers for anything so far. So some we just follow, okay? But some start as moderate and progress to the next phase very quickly. That's why you still need to keep an eye on what's happening. Most patients, though, do require treatment because their counts are really low. They can't really function with this low blood counts. And then we talk about treating the patients, okay? And then how long can you wait? This is a important conversation because it's a rare diagnosis and it does take an expert pathologist and expert clinician to come together to give you the diagnosis, right? So sometimes what we see is patient goes from ED to ED, primary care to a different community physician, and all these stops, scheduling, taking time off work, coming, there's delays leading up to the diagnosis. If that delay is more than 3 months, what we have seen is the longer it takes to start treatment, if you do require treatment, there is more damage to your stem cells. So quicker you can get to that expert, quicker, more we can talk about this disease, more we raise awareness. This is one problem. This is what we hope to do, to cut down the time between diagnosis and treatment. And not, 3 months is okay. Beyond that is a little bit irrational for the patient, and it's not good for the patient because their outcomes or response rates are a little lower compared to the other people. Um, Sometimes when they're being worked up for bone marrow transplant, it can be a little longer. If the plan is to go towards a bone marrow transplant, because that's such a definitive therapy and it's taking a little bit longer, that's okay. But on an average, 12 to 15 weeks is where we feel comfortable from diagnosis till to treatment. Beyond that, we would risk some stem cell damage and things like that, okay? And it's not ideal. So, what are some of the drugs you may have taken or heard your family member take or friend take? Okay. So, these are all the different medicines that are used. We'll talk about the algorithm, how we think about it, but I just wanted to give a broad overview of the medications. Some of the medicines you take is called cyclosporin, tacrolimus, or sirolimus. These are immunosuppressive drugs. They come in different doses. Some of them have a distinct smell. People just leave it open and they tell the family, don't come into the room. I'm going to take my medicines. It really stings, and quickly take it and just that time passes in the day. Okay. So those are those medicines. The one most common, the reason you get admitted to a hospital is this drug called anti-thymocyte globulin. Okay. It's a product that's made using animals. So sometimes you'll hear horse or rabbit or porcine, some of those terms, because we take human cells, put it in a horse, and have it make antibodies. Because it's an immune disorder, we're trying to kill our own immune system. We take its serum back and give it as a medicine to the humans that have this disease. It's called anti-lymphocyte globulin or anti-thymocyte. Thymocyte is white blood cells, basically, globulin. So it's typically given in an IV. You usually require a central line, a large pore line. So you get admitted to a hospital, either in your arm or in your chest. They put a big line and give it to you over a few days. Okay. So they could be infusional reactions. You may feel like you have fever, chills, and rigors while you're getting these medications, which is the why you get admitted to the hospital, so they can help you with all these side effects that might come, because it's a foreign protein that is trying to help you, and you can react to this protein. It's called infusional reactions, and most institutions are well equipped to manage those side effects. This is one of the newer medicines over the last decade called Promacta. Comes in different doses, as I show in the picture here. Everybody that takes this medicine knows that there is this medicine, because it's a lifestyle change. You have to fast 2 hours before, 2 hours because there's a food interaction. So everybody, my patients typically tell me they have an alarm. They wake up in the middle of the night, take it, or if they're early bird, they just wake up 3 o'clock in the morning, take that medicine, and don't have their coffee till 5 a.m. or something like that. Okay. So some of the other drugs that you may have heard of is this medicine called Campath or alemtuzumab. It's another medicine that's given, usually used not upfront, but when your disease comes back, that's when it is commonly used. And they give it as an injection under your skin or through IV, can be given inpatient or outpatient. Okay. So what is the algorithm? What do your doctors talk to you about when this specific algorithm is for severe aplastic anemia, severe or very severe aplastic anemia? So it's an age-based bifurcation that we think, am I dealing with a child? Am I dealing with an adult that's less than 40-year old? Okay. So if you're less than 40 years old and you have a good donor, we typically encourage as first-line therapy. Match sibling donor is usually who we prefer, your siblings, if they're able to donate and they're a match for you, and you're less than 40 years old, we send you to bone marrow transplant. Okay. You do not have a donor or you're a little older than 40 years. The outcomes of bone marrow transplant as we age are not as amazing as when we are kids, because of complications that come from that procedure. And there are still other effective treatments for aplastic anemia. The good thing about aplastic anemia is it responds to treatments, okay? So because we have other good treatments, we try and talk about what's called immunosuppressive therapy, okay? Until early 2000, 2010, we did what's called double therapy. So the anti-lymphocyte globulin or ATG that I talked about, people used to get that, steroids, and yes, one of the pills that I showed you. But more recently, we have learned that giving Promacta or Eltrombopag, those colorful pills that I showed you, combining all these agents together, if they give it to you, that the response rates are a little bit higher. So we do what's called a triple drug regimen for people who need treatment for their severe aplastic anemia. It takes time. Bone, I tell my patients, a broken bone takes a long time to be fixed, right? Bone marrow is much more complicated and intricate than that. So it takes time to jumpstart your bone marrow. So we do everything and we close our eyes like nothing ever happened for 3 months. And after 3 months is when we start telling people, let's see what's happening now. Oh, my blood transfusions, every time I come in, I'm only needing every other time. That's the first sign you'll get. Oh, something's getting better. People get really emotional around this 3 to 6 month part because they have seen this like zeros and twos for hemoglobin and like sixes for platelets. And all of a sudden they start seeing 11. And that's twice the number of what they had before. And as a clinician, I think that's the day I look for each of my patients. It's so gratifying to see, oh, it's working. Bone marrow is starting to make baby cells, and then they go completely normal later. So it takes time and a lot of patience on you and on your doctor's behalf to be patient together. And that's why we are there. I think we still see each other. We do the treatment. We still follow our patients very closely because they're needing transfusions. The medicines we are giving are not simple medicines. They have side effects, headaches, cramps. We monitor the levels of the drugs that we are giving you, infections, and so on and so forth. So we still meet every week to keep an eye on things, but we do not talk about is it working for a few months after the treatment. All right. You achieve response or disease came back, you achieve response, but all the counts, whatever the spectrum you fall in, there is a continued surveillance even after the first 3 to 6 months, okay? Because the disease is a lifetime illness. Once you have the disease, for majority of them, it's aplastic anemia. It may or may not come back, and it's fine, but it puts you at a higher risk for what we call late clonal events, like acute leukemia, myelodysplastic syndrome, or the sister disease PNH might wake up one day and start acting up, okay? So it is good to catch these early on. So we keep an eye on our patients and what's happening with them, depending on the scenario, every 3 to 6 months, even when you're in full remission. So who do I send to transplant versus think about just the medicines that I talked about, age of the patient, type of the donor that's available, how there was a young patient who was diagnosed in Honduras. They couldn't transplant her. Somebody told her to go to St. Jude, this 20-year-old girl, cross the border, walk door to door, ER to ER, getting hospital transfusions, and walk to us along with her brother, who's a donor, okay? Because she looked fine, because it was so long after, like this, it took her 6 months to find St. Jude from Honduras, because sometimes she was just walking with no money. So if it's such a long duration from your diagnosis, I didn't feel like ATG would be the best option. We went ahead and transplanted that patient. So but several factors your doctor is thinking about to come up with your treatment plan, and these are some of the most important things. Some markers of your disease help us predict, oh, I really think immunosuppression is the right answer, presence of a PNH clone and another chromosomal abnormality called 6p-LOH. They're markers of immunity, that this is definitely immune driven. So if I give immunosuppression, they're going to definitely respond. Usually we describe response rates around 80, 75%, but I know this patient falls into that 75% or 80% because of these markers. So I really feel confident this is the way we go ahead and should execute this treatment plan, okay? So there's a slight variation between adults and children. In children, we do not give L-Trombopag upfront. For adults, we give L-Trombopag upfront. The response rates are just a little different based on age, okay? The other key element is once you have achieved your best response, you're supposed to come off these medicines. A lot of physicians get confused, or I'm not sure, lack of experience at this point. Sometimes they tend to cold turkey stop the medicines and disease comes back. You're supposed to cut them down slowly. Okay, that is a key component to success for a lot of aplastic anemia patients. Just very briefly, what if you don't respond, okay? I hope this is a rare situation. It's a very frustrating situation for patients, but we have to be honest with each other. If you fall into this category, what do we do about it, okay? There are clinical trials. I know, like I said, it's not everybody. For some people, they actually respond to fine, and 10 years later, the disease comes back. So everybody could be a different scenario, right? Then we repeat the bone marrow biopsy, make sure again, we are dealing with just aplastic anemia or something else, or did they progress to MDS? They could have started as aplastic anemia, but changed to something else. Did I do all my genetic testing to make sure that was truly acquired? It's aplastic anemia, but there are different kinds, right? We really need to make sure type of aplastic anemia is correct, okay? In some of my really, really older patients, like 85 plus patients, the, it looks like an empty marrow, but it was never immune driven. They were born with a certain number of stem cells, and there is just stem cell exhaustion for them. So no matter how much medicine I give, I have a really hard time fixing that type of aplastic anemia. So that subset is a little bit harder to help. But we can still have a lot of stimulatory agents like romiplastin. I'm going to show some data about, and there's some clinical trials ongoing sponsored by NIH and in collaboration with pharmaceutical companies that are ongoing to help these patients. But if you look good health-wise and your disease came back, we typically talk about a bone marrow transplant in that situation, okay? Repeating immunosuppression is a good alternative too. Again, it's a very individualized conversation to each patient. So what are some of the updates? Most patients do good, but some patients need extra help. So we are always looking for better and better agents, okay? So there is a collaborative group led by Johns Hopkins and 14 centers. They enroll patients to do what's called half-match transplant. Usually we used to look for full donor, but we know for everybody, we don't find a donor, okay? Then can you use your mom or if you're a child, or can you use your child if you were that parent as a donor? We call that half-match transplant. Our kids are family members that are genetically related or at least have a match to us. So using some of the modifications of newer medicines, we're able to show in this collaborative study that there was excellent survival using such a technique. There's a complication of transplant called GVHD. It was very minimal when we used all the modern techniques for this half-match transplant. The key that we learned from this small study is that we have to use really high doses of stem cells that we are taking from the donor to rescue or cure you of aplastic anemia. Eltrombopag has a sister medicine called romiplastin, Japanese and Asian, because there's a lot more patients there. They have shown by using romiplastin, they're able to resuscitate a lot of patients who don't have any other alternative treatments. They're not candidates for transplant. So there are other medications on the horizon that can help patients where the disease has not typically responded to the immunosuppression agents. So they have followed a few patients over 3.5 years and showed that they're able to achieve responses and the responses are able to last long enough for these patients. So some exciting stuff happening in the field, okay? So when can I get back to routine? Okay, so this depends on, this is what everybody wants. I dealt with this, we've done everything we needed to do. When can I go back to work? Everything's looking great. So this is where, like I said, we need to be patient. It takes about 3 months to respond. And response can be different kinds, right? Like transfusion independence or completely normal counts. Any of that, that spectrum is still good, okay? So what I typically tell my patients is when you stop needing transfusions on a frequent basis and you're able to tolerate or on a steady doses of medicine, if you're really pushing me, that's when we can think of going early signs of response. That's at least that's the time point to go back to work, okay? Ideally, waiting till your maximal response, so 6 months from the treatment is when I start talking to them about going back into the workforce. All right, so whenever your visits go lower, meaning your numbers are looking good, that's the time to think about going back to work or getting back to your routine. All right, what if I get pregnant? Because we've dealt with this for so long, so many years of experience, now we are able to have collaborative care between whoever is considering pregnancy or is pregnant with aplastic anemia, they need to see what's called maternal-fetal medicine expert, and they have to work very closely with your hematologist, okay? There have been successful pregnancies. They will need, your blood counts might go much lower during pregnancy because we cannot give any medicines with the exception of steroids and some of the more modern medicines. You are able to, so most of the care is what's called supportive care. So you can still get pregnant and have successful pregnancies. Your doctors have to just work together for this successful outcome, and not to be worried if your numbers go low during pregnancy. It is to be expected that will happen. Okay. Um, Exercises, because fatigue is a big issue, exercise is actually key. You may want to avoid any exertional, like high intensity hit is not okay, but aerobic exercises, swimming, things like that are okay. So exercise is good, and just talk to your doctors about how much exercise you can do. Preventing infections, getting your shots, avoiding big crowds. If friends are sick, say thank you. I know you care for me, but stay home. Don't come too close to me. Those are common sense stuff. Washing hands frequently, regular dental care. These are the things that you do to prevent infections. Healthy, balanced diet. There's no real key to this. Food hygiene is important. I always tell my patients when they're neutropenic, cooked meals until your neutrophil counts. If you really love salads, make your own salad. Get the lettuce home, wash it, do your own salad. So there are a lot of misinformation around this out there, but the key is freshly made cooked meals and balanced diet, I think. And also pay attention to your inner self and emotion. It's a key component of this whole thing because you will have good days and bad days. It's important to make sure your family is there to support you. Am I running out of time or are we good? We're good. All right. This is a big thing I focus on because I work in this niche of caring for young folks and adults with this disorder. That cusp of 18 to 25, what we define as adults, youth, young adults, is a really hard time because they're trying to get independent, yet they have this illness they have to deal with. So it's like two things at the same time, and it's extremely difficult. They tend to get lost in the system. Their employments are lower. So they're general, when your employment is lower and you have a condition that requires a lot of support, insurance and things like that, it becomes extremely difficult for these patients. So it is important for your pediatric, for your child, your pediatrician to work with an adult physician at that time to make as smooth a transition as possible. This is a lot of focus of what I do for patients. I catch them early, I let them get used to me, then I take them over to my adult. For the patients who live in Memphis and surrounding area, but people live in all parts of United States, the more we can educate clinicians about this, it becomes younger for patients. In the spectrum of bone marrow failure, we're discovering more and more what used to be just a low platelet count or anemia, now with a genomic driver. Oh, these are low platelets because of this genetic condition. And each of them has a specific natural history. Some of the things, I think one of the sessions you'll hear more about this, so I'm not going to go in detail. They're low, and then there's a risk of cancer following it at certain part in their life. So it's important for clinicians, hematologists to be aware to follow these kids throughout their second, because if you're present too late and somebody doesn't know your history, treated you as another person with MDS, another person with leukemia, these specific conditions may have more things that they need to pay attention to fully for your optimal outcome. Okay. So young adults need special attention because they're all special. um, Again, it's once encouraging compliance is key to optimal outcomes. Um, I told you it's what does survivorship look like? You went through your treatments, you either in full remission or your accounts are looking good, you're back to work. You still have to pay your visits to your doctor because we look at several things. Is the PNH going away? It can go away. Is it increasing? Do they need treatment for it? Things like that. So because aplastic anemia comes with PNH, it's an important marker that we need to make sure we're paying attention to. I've known of cases that the clinician either forgot or did not educate the patient really well. All of a sudden, they come with this blood clots in their belly and things like that, which makes it really hard then to intervene and make this pain go away. It becomes much more difficult. So following serially, you're able to gauge the risk and intervene early on before bad effects happen from these diagnoses. Okay. With all the testing that we have done and invented, we created more troubles for it. Things we do so many specialized tests and find all these tiny changes in your DNA, what we call chip now. And we follow them serially just to make sure. Sometimes it predicts for heart diseases and things like that. So there's a parallel talk going on right now. So your doctor may talk about small mutations they're just following once in a while just to make sure everything's going okay for you. Okay, having these things doesn't mean the cancer is the aplastic anemia is coming back or a cancer is coming. We don't understand this really well. We are in that area where we're just learning more about it. So you have to be patient along with this. We'll give the best information we have and track the clone just to give you full preventative care. I think that's it. Aplastic anemia is, I love managing it because it's so treatable and it's so gratifying to see the blood counts get better with good long-term outcomes. That's the key thing. They do well in long term. Surveillance, I cannot emphasize more. Once you're done with treatment, you're not done. You stick on it, you follow with your doctor. And it's best to avoid any delays. People who are going through it, a new member into your Facebook support group or whatever it is, tell them if they're hesitant about going through treatments, delaying it is no good. So just move on. If you need treatment, handle it. Okay, those are the key points. Thank you. I hope you found that informative. Thank you so much.
Thank you very much, Dr. Thota, for the wonderful presentation. We'll go ahead and take some questions. Does anyone have a question to start? Yeah. Yes. Okay, hang on.
Hi, thank you. I have a lot of questions.
Mm.
One of them is I have a stable levels right now, but all the time I'm asking if I come back, what happened with me? Because I'm not young to make a transplant and I don't have donor in my case. And I want to know, that I know that you say that the survival is like depending, but in this case, when you don't have a doctor specialized in this illness, it's difficult. And this is my case in Wisconsin. Is not too much knowing my illness.
Mm.
And my question is that what happened if I back the levels, because I never know, and I didn't know before when I was sick. So
Mm. Yeah, well, thanks for sharing your story. Well, I think lack of expertise is where this service comes in picture. So at some point during my presentation today, either this or in afternoon, I'll share my contact. I'm always available for anybody with aplastic anemia or rare blood disorders, okay? So all you need to do is email one of us, okay? Now, it will always not be HIPAA compliant, okay, because you're not in my medical system, but we will, most physicians that are on the AAMDS page have expertise, not just me. If you see the previous recordings, anything, everybody, we understand that. We understand the rarity and the uncertainty a patient feels. We're going to talk more about it later. It's really, really difficult, your situation, when you don't have. But these experts on the web page, including me, we work, not all my patients are in Memphis. They're in the between Memphis, Dallas, Little Rock, Nashville, a lot of Mississippi states. It's about 150 miles that our patients travel and come. They get their transfusions. I just give the ATG treatment. They go home. I get weekly cyclosporin levels, and we work together. A lot of televisits have made it easier right now. The longer you go with the illness and you see blood counts, your confidence level boosts up. I think I'm going to be okay. There's always a certain uncertainty, but like I said, you have to hang on to that. Aplastic anemia is highly treatable condition. Not having donor may feel you vulnerable, okay? But like I said, even when you relapse, there's so many new drugs coming. ATG, repeating ATG is, if you have responded to it, again, there's lots of options, not to worry.
Dr. Thota, what is the signs of relapse of, if you're
Yeah.
doing well,
Great question.
how do you know when the counts are coming down and you may be looking at relapsed aplastic anemia?
Okay. A fantastic question. Okay. So numbers fluctuate, right? Platelets this morning are 150, this afternoon are 109. Okay. It is a consistent pattern. Okay. Fluctuations can happen. Okay. You just had your period, your hemoglobin's a little low, it doesn't mean anything. The single low count doesn't mean anything. So consistent trend towards going down, the trajectory of your blood counts is the easiest way. So relapse, there's no standard definition, but any downtrend in your blood counts from your best response is earliest sign of relapse. So that's how you recognize it. But there could be two counts that are like 109, 99, 89, and then it's 109 again. Okay, so it's that trajectory. And it is very common when L thrombopac stops, platelets go from 300 to 100, and then they stay at 100. So you have to correlate with the treatment that you're on at that point, and or a viral illness that just happened. You're responding and you came down with COVID or something, all your numbers like go down, and then 3 months later they're up. So it has to be interpreted with all those things in context, and not to worry about single time point. It's over time you'll recognize it, but blood counts going down is how you diagnose it.
Thank you. Ron?
What about the variations in the reticulocytes, or is that how you?
Yeah, I love reticulocytes. So the great question. So reticulocytes represent what's happening in your bone marrow. Just they are baby red cell. Every day, I think we make over 1 billion cells. Okay, majority of them are actually reticulocyte because we need hemoglobin. Okay, it changes from day to day to day. It is again a trend of it. If it's going down consistent, you're getting anemic, and your reticulocyte count is supposed to go up if your bone marrow is working fine, okay? But if your bone marrow is not working fine, it goes down. But if your hemoglobin is normal, your reticulocyte is normal. You don't need so many baby red cells. Again, has to be interpreted with the context, not a number is not important. Hemoglobin going low, reticulocyte going low together is a sign of relapse, okay? But it's multiple time points that will help you diagnose that.
Hold on, one here.
Hi, I have a question. Are there any long-term studies on those who have received multiple rounds of ATG and ALG and a follow-up? I know that some of those patients, they see the titers or the serum in their blood long-term. What are the results of those possible studies?
Okay, great question again. You're talking about long-term survival for patients who are relapsed, okay? I'll give you an example of my patient and go back to the studies question. So treated as a 17-year-old with ATG, did fine. 10 years later, disease came back because they had a 10-year duration of response from the last round of ATG. That's the type of patient I would typically select for another round of ATG. My hope is that they will get 10 more years or beyond that, okay? So it tells you they have an immune-based disorder. So using some sort of, the second time it comes back, you can modify your treatment. Usually you come off cyclosporin when you achieve remission, but when your disease comes back, you can use cyclosporin for a longer time to make that relapse not happen very quick, all right? More often than not, even for relapsed aplastic anemia patients that are responding to immunosuppression therapy, their long-term survival is compared to age-matched peers, okay? There is a 10% lower rate because of leukemia and other things that happen to them. Okay. But in general, people who have aplastic anemia and have responded to immunosuppressive therapy have good long-term outcome, very much comparable, not exactly, but very much comparable to age-matched peers. Does that answer your question? You're
The
talking
presence
about
of the
chimerisms. When you say titers, are you talking about chimerisms of the bone marrow, or are you talking about titers of the medicine in your body?
I've read studies where they look at long-term survivors and they can still detect serum of ATG or
Ah, okay,
ALG
got
long-term.
Yeah, yes. Okay, I know what you're talking about now. Yeah. So ATG is a medicine that can stick around because it's a biological medicine. When your body sees it, and it can stick around in your body a year later, 2 years later. I do not know beyond 2 to 3 years if they can stick around, but it's a medicine that your body doesn't always eliminate. There's always a little bit of it left over, which is what you're referring to, I think. I don't exactly know, like 5 years, 10 years, it's still detectable, but we believe it's detectable in a very small proportion in those long-term survivors.
Good morning. I have two questions. One is, you mentioned specifically hepatitis as one of the viral diseases that has been connected to AA. I'm wondering if you're seeing more cases now that COVID is amongst us.
Mm.
I was diagnosed with AA about 3 months after having COVID.
Mm.
I also had the vaccines, so just kind of curious for my own sake. And then my other question is weaning of cyclosporin. When, how carefully?
Okay, good. Awesome. Great questions. Very timely for the COVID. I don't know, it has been my observation since the pandemic and like lifting all the restrictions. There's been a lot more. The viral season seems to start like July all the way till March. There's probably like 1 or 2 months of not having. So the exact way to actually answer that, it's a little bit delayed because national registries don't report out true numbers. There's a 5-year lag in reporting. We have seen some like blood cancers, especially T cell lymphomas, other lymphomas, like some surge. I'm like, I've just never seen this much. But this is like a very biased view of what we have seen as an institution. This usually we get 50 of these cases. I just feel like this year we got 85 or 90 of these
Thank you.
cases. So aplastic anemia, I did not see any specific increase during COVID time or pandemic, but several associations of I had a viral illness and this happened. A lot of those stories happened. And then the other thing about tapering, I go down, my rule is 25% of the dose. I cut by 25% of cyclosporin, 20 to 25%, and not any time closer than 6 weeks, because once you make a change, your blood counts change based on that dose 6 to 12 weeks later. I go very slow. Every 3 months, I make a small change. So I take a long time to taper, and I found success in that strategy. And since I moved to Memphis, I've been trying to impart it on my other colleagues too. Some subset of patients, they go down within 3 months and they're fine. But those where the numbers are not completely perfect, I take a long time to taper them. And that's what the study showed to the NIH cohort. They used to say stop cyclosporin, taper cyclosporin. Now they say extend it for 2 more years, and which is what we have always done. Just the cyclosporin, long taper. You can consider tapering since year 1 too. Again, it depends on your numbers. You achieve full normal recovery, you can stick with the old rules. You're a partial responder, take a long time to taper them. Long term, it's not so strict that we have to stop it. That used to be what we taught, but the story changed.
I have a quick follow-up question on infection and then the relapse. If you have a moderate disease, I mean, you're worried about progression, are there any risk factors such as infection and other than that that would prompt you to look at the blood counts
Yeah.
and the genetics?
Moderate aplastic anemia is a spectrum. They're like I described the case that I take care of, they are moderate and stay moderate, but a lot of moderates in the beginning, the first few months, there's not really good predictive markers there. It's a research question that you're asking. Who is it that patient that progresses to severe versus who is it that just going to stay moderate? We don't have good predictive tools there. Okay. Um, some percentage stay there. Some need small amounts of treatment, like viral infections can make your counts go low, but it could be temporary. It's key to make sure 6 weeks later it's actually better. If you're really thinking of, that's where expertise come into picture, I think, to talk with your clinician. I'm like, do I really need it, or was this because of this viral thing that I just had? Okay. Because there are no strict rules around moderate aplastic anemia, it's a little bit harder. You have to rely on your physician for the expertise there.
Any other additional questions?
I have a plastic anemia, very severe, and then I have a 50% the myelodysplasia, because they made twice the test to verify that not be a plastic anemia or the that you say before.
PNH?
That yes, and what happened if I go to the second illness?
The PNH you're talking about?
No,
or
the
MDS?
MBS.
Okay. So can you clarify? They said you have no MDS, or did they say you
No, I don't have it.
do
thank
MDS?
God.
Only
But the doctors say that it's sure that I'm going to. So this has made me nervous, and it's not really happy to know it, because I don't know what is the treatment for that, because if now I don't have any other treatment, and I use a thrombopack for almost 15th month, that is normal only 1 year, and also I'm using for a long time the
Cyclosporin.
cyclosporin,
okay.
and it's only to know what happened.
Yeah. You're asking your risk of other blood cancers, I think. Yeah. It is the heavy news of aplastic anemia that there is that risk. Okay. But it's not 100% that everybody gets MDS. Okay. It's a very small percentage of patients. You're concerned about, oh, we're only supposed to take Promata 6 months. I took a year. We don't know to that granularity, but what we know is by using Promacta upfront like that, it did not make people have more MDS. That's what we know. Now we have like 5 to 6 year follow-up. We know, but in adults, by using Promacta, that no more people got diagnosed with MDS. Okay. We have to like, there is that risk of MDS, and it's a treatable condition. Okay. So we'll cross that bridge when we get there, I guess. Early intervention is important. Your doctor's following you and noticing those changes. Majority of the time, it doesn't happen. Okay. So that should be the thing you hold on to.
Another question is, for example, in my case, I see that the oncologists sometimes only see the illness, but the medicine, and it has a side effect. And sometimes we get another kind of things, and they send you only for the primary care, and the primary care make things that you are not doctor, but you know that is wrong.
Yeah.
Because nobody know that you can get these kind
Yeah.
of medicines or other things, and also they think that you are not related with the medicine, so you don't know, and it's not true, because when you are really sick, you have to investigate, and
Yeah.
and read and read and read. And also, for example, in my case, now I have blood in urine, and I may stop it because my primary care is a maternity leave, and my doctor say, "Oh, I can send you to the
Urologist.
urologist because I can know nothing about that." No, because the blood is my problem and it's your problem because you are the oncologist. So now I'm really concerned about my health because I was stable, and with the I have like a 3 weeks with the blood in urine, and it's not infection. So I'm dusting blood, and you know that every drop of blood is important for us. So I don't know, really, I don't know. I have
no,
to
my
move
heart
to,
goes out
to
to you.
Tennessee.
Yeah, no, absolutely. We can talk offline about your specific concerns.
Yeah,
But I do tell,
thank you so much.
I'm culprit for some of the things you're telling about your doctor too. I do manage the hypertension that comes out of cyclosporin, okay? But I tell the patient, I'm not the best hypertension doctor. This is what I know, and this is what we're going to do. You're good with that? Like, it's always a shared decision. We are not that old 60s doctors that we do everything. We've become so specialized now that I think the younger ones, I think, feel a little bit uncomfortable managing liver failure, or they try and seek opinions. If you're able to make that appointment, I think what they're looking for is, we can do this. Am I thinking the right way? I hope they're not punting the problem to somebody else, but just trying to seek I hope, is the way your doctor is looking at it. That's how I look at it. Like, I start with something, but I get uncomfortable. I'm like, we really need the kidney doctor here, I think. That's how my mentality is. But I hope adult doctors collaborate and work as a team better. I do wish that for our medical community. What you're telling me is some of the disjoint we see in adult practices sometimes. I cannot deny that.
Dr. Thota, do you find it helpful when patients like track their symptoms in between like the appointments with you? So when they come in, you can kind of go over like what's been happening and when it's been happening. Do you find that helpful as an expert?
Extremely helpful. Who I struggle with is those who don't keep track of symptoms, and I have to tell, you're sick. You should have come 2 months earlier. I love when we intercept early and before things go bad, because we all want to fix things. And sometimes when we can't and we knew we could have, it bothers us the deepest. So I love it when they're like, I just don't feel well. When my patient tells me that, I pay attention. Like, they have my undivided attention. I just don't feel well. So tracking their symptoms is they know their health the best. We can pretend as much as we want, we understand it, but something is off, patients tell you first.
Any more questions? Okay. Well, thank you so much, Dr.
Yeah.
Thota, for sharing your time and your expertise with us today. The session was recorded, so it will be available on our website, I would say within 7 to 10 business days.